Welcome to JAMA AI Conversations. I'm Roy Perlis, Editor-in-Chief of JAMA AI, and I'm pleased to welcome today's guest, Dr. Mello. Dr. Mello is a professor of law and health policy at Stanford University and the senior author of the recent JAMA Viewpoint, Ethical Obligations to Inform Patients About Use of AI Tools. In this article, she and her co-authors outlined a framework that could guide healthcare organizations in deciding when and how to disclose use of AI to patients. Michelle, thanks so much for joining us today.
Thanks for having me.
So I guess to start us off, why now? What motivated you guys to sit down and write this piece now rather than 6 months ago or 2 years from now?
Two issues. First is I'm a lawyer, and I would say the most frequently asked question about AI right now that I get at conferences and over email is, what should I be telling patients? So it seemed like time to provide some advice. And the second is that it's a problem we faced here at Stanford. I lead a lab called MPhil AI that does ethical assessment of tools that are proposed for use in our hospitals. And we have to make this decision each time for new tools that we're rolling out. We realized we didn't really have a framework for that decision and for ensuring consistency across use cases.
And you start off in the article by pointing out that all kinds of tools, rule-based classifiers, up-to-date summaries, references, we use them all the time without informing patients. Could you just say a little bit about why AI gets treated differently or maybe should be treated differently?
Well, I think the first question we started with is, should it be treated any differently? When we interview physicians about their views on the ethics of AI, they often don't see it as being substantively different from any other kinds of decision supports that they use. And they know that patients, much like passengers on an airplane, don't need to know every gore detail of how we're getting to Cincinnati as long as they get to the right place at the right time. So why would we have an exceptional view of AI? I think the answer is that as a lawyer, I understand that our views about informed consent or notification are very much driven by what we think is material information to patients, meaning what do patients themselves care about. And the survey evidence is pretty compelling that right now, patients do see AI differently than other kinds of medical decision-making processes. Recent surveys found, for example, 60% of U.S. adults are uncomfortable with their physician relying on AI. Almost 80% say they have low expectations that AI will improve important aspects of their care. About a third say, I trust healthcare systems to use AI responsibly. The other 2/3, not so much. And 63% says, it's very true, I would want to be notified about use of AI in my care. So it matters to patients.
But don't you think that's just because it's a new technology? And if you had done that same survey 20 years ago, it would have been computers.
That's very possible. And, part of this is probably unfamiliarity with how AI works and how it is or is not different from other kinds of clinical supports, as well as probably ignorance about the extent to which physicians already rely on an array of other tools, including simpler predictive tools that might be much worse performing. So we may well move from this stage of awkward adolescence around AI use and understanding into a phase where it is a part of not just everyday care, but people's lives every day, every aspect of our lives. And we should be ready to adjust how we talk with patients about it, or whether we talk with patients about it, according to the state of the art.
So that's interesting because I guess it allows that maybe right now we need a different approach to consent than even a year from now, 2 years from now.
I think so. And maybe another way to think about it is that even though most use and development of AI in our hospitals isn't done as part of a research project, it is in a sense kind of experimental. And when things are in a very early stage of use and evaluation, our conventions around research say that in and of itself is a reason to tell people so that they can make decisions about whether they want to be in the vanguard of people that it's being used on. And so arguably, especially because this isn't treated as research and it's not overseen by an IRB and it doesn't have, staged clinical trials, that's an even greater reason to bring patients into the equation in decision-making in appropriate cases.
So I would guess, and I haven't seen the most recent statistics, that a huge number of house staff and fellows and some of the attendings as well routinely use tools like open evidence now when they're taking care of patients, right? So they walk out of the room and they look at their phone and they ask a question. Should we be disclosing that to patients?
Again, my intuition, not having talked specifically with patients about this, about data-driven, just an intuition, is that most patients won't particularly care about that. But there are two things about AI that I think might be a reason that they differentiate it, aside from just the mere fact that it's new. One is that it's generating predictions for them. Now, up to date involves synthesis of predictions made from large data sets. It's not quite the same thing as having a tool saying, should Dr. Perlis receive a specific chemotherapeutic agent, or should he be screened for hypertrophic cardiomyopathy? And the second reason is that for generative AI, it is behaving in some instances as though it were a human. For example, when a physician sends an email to a patient that was generated by a bot. And that just, I think, fundamentally places it in a very different class of tools than something like UpToDate.
I guess I get part of that, although there's an element that feels a little lawyerly about it, because if I go into a tool like that and I provide the clinical information, I'm going to get back its recommendation for what I do in a particular circumstance. So to me, it feels like some of that is clinical decision support. It is operating like a consultant might, but...
Well, maybe the way to think about it is that many kind of tools kind of take that to the next level. They are generating more of a customized recommendation that appears to be even more tailored to a specific patient, yet we all understand, those who study AI, that there will always be omissions from that algorithm. So I think, what your questions are pushing towards is that probably this is the distinction more of degree or kind than a black and white distinction. I think to patients, though, they're in a place where they can't begin to understand the gray. But what they are telling us is, I have a degree of distrust about this technology. And they're telling us this at a time when medicine is facing greater public distrust than at any other time, probably in our lifetimes. So again, I think both of these produce an argument that we should be thinking hard about patient notification and consent. They don't, as we make clear in the article, lead to a conclusion that it's always best to disclose or consent.
One of the things I really liked about the article was the focus on sort of meeting patients where they are. And I appreciate the idea that trust is as low as it's been. And so anything we can do to enhance that trust is probably worth considering. Do you worry that the consequence might be actually diminished trust, though? I think about all of the things we do in the hospital where there's an evidence base that might not be so solid, or that use technology that can fail. IVs fail sometimes, the devices they're attached to fail sometimes. Do you worry that all of the consenting actually makes people less trusting and more anxious about their care? Or is that just, we're erring on the side of over consent because it's the right thing to do, even if in the near term it makes people trust us less?
I do worry about that, and I don't personally err on the side of over consent. Actually, the conclusion that we reach from our analysis is that probably in most cases, not even a notification is appropriate to give to patients, much less a full consent. The number of cases where there's a good argument for full consent is pretty limited. And part of the reason for that is that when we've interviewed patients, as we do every time we evaluate a new AI tool here, they very often say things like, when you're in the hospital, you're already overloaded with information and you've put your trust in the hands of these people in a very precarious situation. I'm not sure that were I to be told about this particular AI tool, it would do anything more than produce anxiety, especially in situations where I don't actually have any choice about whether it is, will be, or was used on me. It feels to some patients actually more like a waiver of responsibility. Just FYI, you've been informed, now that this tool was used in your care. So ... you can't sue us, you can't complain later on, and so forth.
And I loved that point because that really resonates, right? What are you going to decide? No, you know what? Now that I've read the consent form, as you're about to wheel me back to the OR, I think I'm going to not go ahead with it. My worry is that we end up consenting people when they don't necessarily have much of a choice. I read the piece sort of ready to argue with you. And, unfortunately for fireworks, I mostly felt like I was agreeing with everything y'all were saying. One of the things I wondered about, though, is how would you think about the fact that when I walk onto an airplane, I don't have to sign consent, even though a big chunk of my flight is going to be flown by a computer, right? Like, why don't I have to consent to the autopilot thing? How would that fit into your framework? What's different?
I think it fits neatly into the framework as a case in which not even notification would be required, much less consent, because you, as you've said, have absolutely no agency. You have no ability to turn that thing on or off, to fly on a flight that doesn't have an autopilot, to exercise personal oversight over how the autopilot is working, et cetera, et cetera. And the framework that we articulate encourages physicians to look at two factors. First, is there something the patient can do in response to information that's meaningful? And second, is there a degree of physical risk involved? Now, the airplane example, of course, involves physical risk, although the evidence is probably, I guess, overwhelming that not using it entails much greater physical risk, but it doesn't involve any kind of agency.
And I wonder about the responsibility part of this decision, that it's tempting. You alluded to this earlier. It's tempting for organizations to say, well, they signed consent, so it's okay. Can you say more about why relying too heavily on consent might actually let organizations off the hook or make them feel like they're off the hook for worrying about the AI that they deploy? It's like they're sort of pushing the risk onto the patient who, they signed the form.
Yeah. I mean, I think the number of cases where it would actually push the risk onto the patient is very low. Like as a legal matter, you don't receive a get out of malpractice free card by having your patient sign an informed consent form. You might avoid an informed consent claim, which is an additional kind of legal claim that can be layered on in a medical malpractice case, but it doesn't get you off the hook for behaving responsibly. But I think that what it can do is create the impression that you are substituting awareness of an irresponsible or dangerous practice for actual work to minimize the risk associated with that practice. It can create that perception on the part of the patient. And it can create that in reality if organizations start to, over time, develop the view that because we're transparent with patients, we have a kind of moral license to be less careful. And we've seen that kind of mentality develop in other places that rely heavily on disclosures, that it somehow creates a freedom now that the person has assumed the risk, like quote unquote, voluntarily, which of course is not a good description of medical care at all.
So what do you think about the responsibilities of organizations to publicize their use of AI in other ways, right? To put it on the website or in the brochure, your surgery will be assisted by an AI device, or we're using, because it's sort of funny to me that a lot of health systems are very excited to publicize their use of AI, but they don't necessarily get into the specifics of where patients might encounter AI in their care.
Yeah, it's a great question. And, one of the reasons we thought about that pretty carefully is that the framework that we're proposing doesn't result in a lot of cases where patients are going to get a direct notification about a specific AI use case. But we didn't want to leave the impression that we feel like that means there's no transparency obligation at all. I would think about this in the way that I think about other patient safety efforts that go on in the hospital, that a responsible hospital is going to communicate with patients about the efforts that it makes to keep them safe. And also, in this case, to ensure that its workforce is, rested, ready, and has sufficient morale to provide good quality care. And indeed, when we interview patients, this is the kind of thing that they tell us, you don't need to bother me with this right before surgery, but I'd like to know generally how the organization is using AI, what are the types of functions that it performs in the hospital, but even more importantly, what steps it takes to make sure that that use is safe and responsible and is improving the care and improving the staff experience. So that's where I think, however anemic it may seem, basic public communications, whether on a website or in other fora can be helpful in letting patients know this is happening. It's a good thing that it's happening. And we know that because we do X, Y, Z to measure the effects and make sure that it's working well for people.
So speaking of working well for people, I have one last question for you, which is in the article, you talk about the patient perspective and involving patient representatives in AI governance. And I would say that's something we hear a lot at meetings talking about AI, but seem to still struggle to accomplish. So I'm curious, not so much in the paper, but in your lab and your lab's work, how do you involve patients in the process? What's a way to be respectful of their perspectives without always only having the one or two identified representatives speaking for them?
Yeah, I mean, it's a puzzle that afflicts patient engagement work generally that, you can't do a big survey all the time. So you're always going to be dealing with a small and select group of patients. So you do kind of get a limited range of perspectives. Then with AI related work, you add on the complexities that you want them to talk to you about some things that most laypersons don't know a great deal about. So our process is by no means perfect. We're always looking for ways to improve it, but we have found a lot of value in creating a learning community of patients. We have 10. They are diverse in many respects. We're finding that some of the most important aspects of diversity are not the usual suspects, but their professional backgrounds and their care experiences have been extremely important in making sure that we're hearing diverse things about AI. And we train them. We provide training in how AI works, both at the outset and on an ongoing basis, partially through formal trainings, but also through the practice of having monthly focus group discussions with us, learning about new AI tools, receiving our reports. They learn what we had to say about the ethics of each tool. They have an opportunity to give feedback iteratively. So it's a relatively modest level of investment, but I think there is some investment required in getting people up to speed. But quite honestly, the investment is, I think, lower than a lot of people would make it out to be. We have been amazed by the quality of insights that we get from even a small number of patients with relatively little experience.
I think that's a perfect place for us to end today. Michelle, thank you again for joining us and for sharing your perspective on what is truly a pressing ethical question in AI and medicine. I also think after you're a guest on 3 different JAMA podcasts, you win a toaster, so we'll make sure to send that your way too. To our listeners, if you'd like to read the full article, you can find the link in the episode description. To hear more JAMA Network podcasts, visit us at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening, and we'll see you next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.